Hi, my name is Natasha Remy. I will be presenting to you today about antibiotic use in the neonatal intensive care unit. More specifically, my research is about and name can health information technology decrease antibiotic use in the neonatal intensive care unit. A brief summary about my presentation. It was estimated that approximately one-third of all hospital patients receive antibiotics, and that of these patients, an alarming 50% did not require this therapy. Research has estimated that antibiotics are as much as 10-fold higher in intensive care units than the general population. 10-fold. Of the 95% of infants, more specific to me, who receive empirical antibiotics in the neonatal intensive care unit, in the first postnatal age, it was found that only 1 to 5% have a positive blood culture result. And that is very alarming because we're giving antibiotics for bacterial information, and at the end, we get to know that only 1 to 5% have positive blood culture results. This practice leads to the development of bacterial resistance and other problems that are more specific to infants. Health information technology can assist in reducing the use with a better diagnosis of bacterial infection from information obtained from both the maternal and perinatal data. What this went about saying is that if we got information from the maternal side and the events surrounding the birth of the baby, that can assist the health providers in making a better decision about whether or not to treat an infant or not. So what? Why do we want to be aware or be careful with our antibiotic use? Research has found that the choice of perinatal and early onset neonatal antimicrobial agents have facilitated the emergence of organisms which cause late onset sepsis. And it has also altered the antibiotic resistant pattern of organism that causes early onset sepsis. The overuse of antibiotics, however, has permitted bacteria to evolve defensive, making some bacteria inadequate against strains of bacteria that continue to appear in hospitals. And these bacteria include things like Clostridium difficile, and if you heard about MRSA, which are multi-drug resistant Staphylococcus aureus, and the famous CRE and Enterobacteria. It just means that our antibiotics, which were so precious to us, are not doing the job that they were supposed to be. That these bacteria, often called the nightmare bacteria, have evolved defensive and strains that antibiotics cannot even touch. They just go on, and somebody could quickly die from these infections. Clinical manifestation of bacterial infection in the neonatal period are often non-specified and non-localized. It is therefore not logical to use clinical manifestation alone to diagnose bacterial infection in the neonatal unit. What this is going to say is that if you're going to have an infant with a bacterial infection, they normally present to things like difficulty feeding, tachypnea, bulging fontanelles, and these clinical manifestations are not specific to just bacterial infection. A bulging fontanelle can mean infection, however, it can also mean fluid overload. However, a common practice in the NICU is that antibiotics are given to infants with negative blood culture. The decision to administer antibiotics is complicated by the fact that infants are uniquely susceptible to bacterial infection and neonatal sepsis. Because what a mother has, an infant can have and can get through the birth canal and all that. Infants are uniquely susceptible to bacterial infection. And research has shown that neonatal sepsis is one of the leading causes of infant mortality and morbidity. Having worked in an NICU for over 5 years, I've come across many infants being given initial antibiotics and not given a chance to even transition from intrauterine life to extrauterine life, and later have negative blood culture. Antibiotics are precious, and every opportunity and method should be utilized to preserve our precious entity. What I want to stress on is that there is a transition from intrauterine life to extrauterine life. The baby used to get everything done by the mother. Now they're asked to breathe for themselves and they're out in the cold. So they will show signs that they're not happy being outside. They will show that tachypnea, they will show the grunting, they will show the nasal flaring. But if you do give them a chance, they will transition. However, because these manifestations are also signs of bacterial infection, you find that people, doctors, physicians, and even nurses sometimes say, treat them with antibiotics. However, if you give them 12 hours to 24 hours, you will find that the transition is made smooth. The grunting will subside, the tachypnea will subside, the nasal flaring will subside for most infants. Okay, so how did I go about conducting my research? Well, I went online to various search engines online, and I found the most recent publication on antibiotic use, and also went about interviewing about six physicians on whether or not antibiotics, what are the views of antibiotic use in the neonatal intensive unit, and whether or not they think that having access to information technology can potentially influence their decision to administer or prescribe antibiotics in that age. What I found, antibiotic therapy was found to be the most commonly used therapy in the neonatal period. There's a growing rate of antibiotics in the neonatal intensive care unit, and it has been attributed to difficulty in physician accurately identifying and distinguishing a bacterial infection from a non-bacterial infection. Health information technology was found to be a potential asset in aiding physicians in that decision and can potentially reduce the number of unnecessary antibiotic prescribed. So it was found that physicians said, well, if they have computers available to them, that they were more likely to Google whether or not, say, if a mother had rupture of membranes, was the infant at risk for getting sepsis, or they were more likely to get algorithm at their disposal to see, okay, this baby is showing sign of infection, should I give this antibiotic and for how long? So all this information will be at their fingertip. They will know if mother had prolonged rupture of membrane, did she had a difficult labor, did the baby pass meconium during labor, what are the stresses the infant went through that can potentially lead to bacterial infection. In conclusion, the decision to administer antibiotics is complicated by the fact that infants, like I said, are uniquely susceptible to bacterial infection, and the fact that neonatal sepsis have been found to be the main cause of morbidity in that group. So you will find physicians have said, and it has been documented, that said the benefit outweigh the risk. That is what they're saying. They will not leave a premature infant showing signs of infection when prematurity is a risk of infection already, that they will treat regardless there is not a risk there, and that is the problem. We need to influence this decision that they're making, because antibiotics are precious to us. Without antibiotics, we cannot treat bacteria. We have bacteria growing defensive, and this is going to pose a financial issue and a financial burden to all of us. And I also wanted to make a point also, is that as healthcare providers, we need to also continue the antibiotic therapy